Good afternoon, everybody. Just switching my mobile phone off as well, so I didn't interrupt myself. So, as Chair's already said, I'm Jenna Abell. I'm a Programme Manager for Staffordshire and Stoke-on-Trent Partnership Trust. We're one of the largest partnership trusts in England, integrated health and social care organisation, and we operate some core community services such as district nursing, community matrons, health visiting, intermediate care, and we also have 5 community hospitals. We're split into 2 divisions. We have a northern division and a southern division, and the work that we're talking to you about today is based in the northern division, which is where we have our 5 community hospitals. So today we're going to talk to you about the work we've done in the community hospitals around really educating our staff around dementia care, and also the work of the EMI stay-at-home service, which is a really crucial service in terms of keeping people at home, but also enabling us to discharge patients from our hospitals. So we'll talk to you about the work that we've done, the journey from hospital to home, some of the challenges that we face in North Staffordshire, and also, I guess, to try and reiterate the importance of a whole system relationship. So if we just start off. So what we know is that patients who have dementia, when they are in hospital, they don't function well because they're in unfamiliar environments. They find it really difficult to adjust to new environments and routines, which can cause them great distress, which is often compounded by cognitive dysfunction, perceptual changes in short-term memory functions, and communication skills, which can really present some problems for these patients when they're on our wards in terms of how they feel within that environment, but also in terms of how our staff manage those patients most effectively, really. This is just a slide that really, I guess, explains what most of you already know in terms of how it feels for those patients when they're in our hospitals. And this will be the same as whether you're in an acute hospital or within a community hospital or any really, I guess, residential setting as a dementia patient. So we know the feelings of not understanding why they're there, what's happening to them, not understanding sort of why they can't be at home or go back to their familiar environment. I think all of us would say that it can be daunting and frightening going into hospital. I don't think any of us would say that we'd absolutely want to be there, but what we know is that for those individuals with dementia, all of those feelings can be very much exacerbated, and it's about us understanding that and how we manage our approach to those individuals, really, so that we get the best for them and the best out of them. So again, I think it's well evidenced that prolonged hospitals in stay result in higher risks of hospital-acquired infections. There is a continued exposure to hazards within the ward environment. There's the inability for the individual to settle and stabilise, which can actually skew the presentation of that person, making it really difficult to assess them and to make sure that we put them in the right place on discharge. Quite often we see, don't we, where we assess individuals in a hospital setting and we think the best place for them is a residential home or a nursing home, and actually there's good evidence to suggest that actually those individuals could go home with the right package and the right support system in place. The reaction of the individual with dementia can often result in us contributing to their problems. If we don't understand their stresses and triggers and their condition and how to manage that, then actually we can make their experience much worse. And we know that delayed discharges have a direct effect on quality outcomes and mortality for patients, and that's especially so for those with dementia. And I think what we were saying on the train actually is that a hospital stay, when it's timely and right, is brilliant and can have really positive outcomes for individuals. But there's a point where it becomes a negative impact, really, because when you get that optimal point of a patient that they're ready to be discharged, actually the longer you keep them in hospital, the more that you disable them and the more difficult it is, I guess, to discharge them. And I know locally we have instances of EMI and dementia patients who have actually been waiting 2, 3, 4, 5 weeks to be discharged, and they're actually ready to go. So there's a big challenge, not just for us locally, I think nationally, in terms of being able to move these patients into the right setting at the right time. We also know that actually to assess a person with dementia in hospital poses many challenges. Most will function, we know that they'll function much better in their own homes and familiar environment and routine, and that actually being in hospital for long periods of time can result in them being unable to recognise a member of their own home and usual routine. So it really does skew the way that they present I think we all would say a hospital is not the right place, and none of us wants to stay in hospital for any longer than we need to. So actually, it's a bit of a no-brainer, isn't it, really, in that the sooner we can get people home, the better. And actually, hospital admission avoidance, wherever possible, for this patient group is really the ideal state. And Diane will talk a bit more about the scheme that we've got that enables those two things to work for us in our local health economy. What we've done in our hospitals is a whole host of education, really, with our community hospital staff. We've got 15 wards, and they offer a range of assessment and rehabilitation, and we've got some specialist rehabilitation units as well. And we've had a real focus around dementia screening and assessment, which has been underpinned by a sequin. We've focused hard, really, to raise awareness around dementia. We use the 6 cognitive impairment tests, which is part of our sequin, and that's a research-based evidence tool that can be used by non-specialist practitioners. I think if you were to Google that, you would actually come across that, and we've used that in our hospitals, focusing very much on person-centred care approaches. We use a booklet called the Getting to Know You booklet, which is something, I've bought a copy today for those who want to see it after the talk, and we use that on assessment, and it's really about understanding that patient, their background, what they were like before they came into hospital, what their likes and dislikes are, how they respond to different situations, so that the team on the ward can really understand that patient and how they respond to different situations. We also have worked through an engagement with patients and carers to form individualised dementia care plans. We've introduced something called the Butterfly Scheme, which is a nationally recognised scheme, which was actually developed by a lady who was a carer herself. And it's quite a simple philosophy of care that involves something called the REACH approach. And that has an identifier of a butterfly for the patients and carers who wish to opt into that scheme. The REACH, very briefly, is about reminding the patient what has led to that moment, explaining what's about to happen, arranging the bedside area to make sense and be accessible and accessible for the patient. We check the well-being, especially cleanliness and hydration, and also it's the history, verifying the history and instructions supported. And that's something that's been rolled out across our 5 hospitals and has been really well received. I can't actually share the information with you today, but I have got the link so that if you wanted to find out more, you could find out more. We've also undertook workshops across a variety of disciplines, and I know Diane and her team have supported with some of that work. We have nominated dementia care champions for all inpatient wards. It's quite a new concept. Each champion has a role description, and they really are the key contact on that ward, around supporting the ward, around all this different training that's happened, around the environment. We've got links with assistive technology. One of our colleagues is sat in the audience at the moment and has met with our dementia champions, so it's a real new emerging role. We're also looking to rotate our dual registered nurses with our local mental health trust. It's not happened yet, but it's something that we are working on, and we've been using the RAID service. So the RAID service was established in the acute trust. For those of you who don't know, that's rapid assessment, intervention and discharge, and they also now support our community hospitals. And we've also worked with Staffordshire University around some training around the 4Ds: dementia, delirium, dignity and depression. That training was really well attended, and we're now looking at how we cascade that across the organisation. We can't recognise that we can't send everybody on a training course, but we're looking at e-learning and what we can do around that, really. So I'm going to hand you over to Diane, and she's going to talk to you about the service that kind of receives our patients from the hospitals, the EMI stay-at-home scheme.
Hello everybody, Diane Evans-Nelmes, staying home scheme. First of all, if you train your staff on the wards to identify people with dementia, to identify what their needs are and what their future desires are, and then you say, well, we've got nowhere for them to go apart from residential care or home on a maintenance package, then people are worried that if those two things happen, that might not be the appropriate exit strategy from hospital that the person needs. That's where we come in. We're a scheme that's provided by Staffordshire Social Services in conjunction with Health, So I'm actually employed by the mental health component of our trust, which is combined Health+Care. We aim to provide a holistic assessment of the person's functional abilities, and the goal is for the individual to remain as independent as possible within their own chosen community setting, be that in home, in an aided bungalow, in sheltered housing. We're a scheme that will go anywhere to assess anybody, basically. The first service user received the Stay in Home scheme in 2002, so we're actually been running now for about 11 years. The scheme offers an assessment of their abilities, what they're able to do, how they function, how they don't function, what the level of input is needed, so as the outcome can be the best possible journey for that person, in the fact that in the long term they will receive a care package that will meet their needs for as long as possible. The length of care input of the assessment depends on need and can either be over a 24-hour period or anything, as we have a scheme running at the moment that's just 2/4 of an hour assessments in somebody's home, which is around medication, building up rapport with that service user who, as I'm sure you know, people who have this condition believe there's nothing wrong with them, so we're gently easing him into community care, because prior to this he's refused all assistance. But we can have people who wander at night, who have specific needs that are identified in hospital, who can even just down to sort of continence needs within a hospital setting. The ward staff are raising concerns about the person going home and being vulnerable from fall